Hello. Hello.
Yes,
Good
sir.
afternoon, sir.
Good afternoon. हामी कतिजना छ अरे स्टुडेन्ट यहाँ त 23 जना मात्रै छ.
Sir, total 76 जना हो जोइन हुँदै होला सर.
ए ओके. अनि हामीले यो क्लास के यो रेकर्ड गर्ने गरेको छ सधैँ?
Yes sir.
रेकर्ड चाहिँ के को लागि गर्ने हो खास?
खोइ सर अब पछि हेर्नलाई सजिलो हुन्छ भनेर त्यो अफ गर्दा नि हुन्छ सर.
होइन सोधेको म के को लागि हो भनेर खास.
सर आज यति नै जान होला स्टार्ट गर्दा हुन्छ
हेलो हाम्रो युवा भट्टराई होस्ट हैन युवा
हजुर सर
अब 39 जना मात्र छ भने त क्लास लिन मिल्दैन है कि साथीहरुलाई बोल्नु एटलिस्ट 50 त हुनु पर्यो थ्योरी क्लास भयो हैन अब 76
हजुर
जना छौ तिमीहरु स्टुडेन्टहरु 76 जना जस्ट 39 40 मात्र भयो त क्लास लिन त गाह्रो हुन्छ नि हैन
हो सर सर म एकचोटि फेरि नोटिस दिन्छु नि
फेरि नोटिस गर नभए अब उनीहरुलाई तिमीले इन्फर्म गरेको थियो कि थिएन अरु स्टुडेन्टहरुलाई
सर थियो नि हिजो पनि गरे हो आज पनि गरेकै हो
हिजो त मेरो त्यो टाउको दुखेर नि क्लास लिन सकिन हैन त्यो त मेरै भयो मेरो साइडबाटकै प्रब्लम भयो त्यो हिजोको अब आज त जस्ट अब एटलिस्ट 50 जना भएपछि क्लास सुरु गर्दा बेटर हुन्छ कि है बढिरहेछ 43 छ हुन्छ ठिकै छ म क्लास सुरु गरिदिन्छु है अहिले फेरि मेरो पनि अरु कामहरु छ अब अरु टाइममा चाहिँ जस्ट स्टुडेन्टहरुलाई चाहिँ एटलिस्ट 50 जना जति चाहिँ प्रेजेन्ट हुनु पर्यो भनेर भन्देऊ न है
हुन्छ सर
हुन्छ ल आजलाई चाहिँ स्टार्ट गर्छु है फेरि अहिले मेरो पनि काम भएर फेरि नभ्या होला भनेर है त ओके आई विल स्टार्ट क्लास सबैले देखिरहेछ है
यस सर
सुनि पनि देखिरहेछ हैन ओके सो टुडे वी आर गोइङ टु टक अबाउट एप्रोच टु सीजर अर एपिलेप्सी है introduction seizure it is an transient occurrence of sign or symptoms due to abnormal excessive or synchronous neuronal activity in the brain and 5 to 10% of the population will have at least one seizure in their life. And talking about epilepsy, it is a condition in which a person has a risk of recurrent seizures due to a chronic underlying process. If a patient has 2 or more seizures, he or she is diagnosed as having epilepsy, and the incident rate is around 0.3 to 0.5%. And now talking about the classification of seizure, seizure is classified into focal seizure and a generalized seizure. Whereas and focal seizure can be further classified as having motor, sensory, autonomic, cognitive, and or other features. And the generalized seizure is further subdivided into absence seizure, where absence seizure might be typical or atypical, tonic-clonic seizure, clonic, tonic, atonic seizure, and lastly myoclonic seizure. And sometimes the seizures can be focal, generalized, or unclear, such as epileptic spasms. And talking about the pathophysiology, a focal seizure originates from a paroxysmal discharge in the focal area of the cerebral cortex. It can be from the temporal lobe or from the parietal or occipital, and the seizure may subsequently spread to the rest of the brain. That is secondary generalization via diencephalic activating pathways. This is focal seizure. Focal seizure usually occurs in one side of the brain, that is in one hemisphere only. Talking about the generalized seizure, the abnormal electrical discharge originate from the diencephalic activating system and spread simultaneously to the all areas of the cortex. That is, it involves both the hemisphere of the brain. Now talking about the focal seizure arises from a neuronal network either discretely localized within one cerebral hemisphere or more broadly distributed, but still within the hemisphere. And the focal seizure can be intact, or focal seizure can be divided into focal seizure with intact awareness or focal seizure with impaired awareness. And the EEG is often normal or show brief discharge, epileptic spikes or subwaves. And the focal seizures can also evolve into the generalized seizure that we call focal seizure with secondary generalization. Talking about focal seizures with intact awareness, the focal seizures can cause motor, sensory, autonomic, or psychic symptoms without impairment of awareness. And the focal motor seizures, there is abnormal motor movements that may begin in a very restricted region, such as the fingers, and gradually progress over seconds to minutes to include a larger portion of the extremity. We call it as Jacksonian march. And and there might be a localized paresis which may occur for minutes to many hours in an involved region following the seizure that we call it as torch paralysis. And the seizure may continue for hours or days. No, we call it as epilepsy partialis continua. And the focal seizure may also manifest as changes in somatic sensation like paresthesia or changes in vision, such as flashing lights or form hallucination, and manifests as change in equilibrium or autonomic functions such as flushing, sweating, and piloerection. And the focal seizures arising from the temporal or frontal cortex may also cause alteration in hearing, olfaction, or higher cortical function. And the subjective or internal events that are not directly observable by someone else are referred to as aura, and it is present in focal type of seizures. And on talking about focal seizures with impaired awareness, there is transient impairment of the patient's ability to maintain normal contact with the environment. The patient is unable to respond appropriately to visual or verbal commands during the seizure. The seizures frequently begin with an aura, and it starts with sudden behavioral arrest or motionless state, which marks the onset of the period of impaired awareness. And it is accompanied by automatism, that is involuntary or automatic behavior such as chewing lip, smacking, swallowing, or picking movements of the hands. And the patient is typically confused following the seizure, such as anterograde amnesia or post-ictal aphasia. As I have told you before, the focal seizure can evolve to generalized seizures. That is we call as evolution of focal seizures to the generalized seizures. And the focal seizures can spread to involve both cerebral hemisphere and produces a generalized seizure, usually a tonic-clonic variety. And the evolution is observed frequently following focal seizures arising from a frontal lobe, and there is a history of preceding aura. Generalized seizure are thought to arise at some point in the brain, but immediately and rapidly engage neuronal network in both cerebral hemisphere. Talking about the subtypes of generalized seizure, first we are going to talk about the typical absence seizure. There is sudden, brief lapse of consciousness without loss of postural control. It typically lasts for only seconds. There is no postictal confusion. There is subtle bilateral motor signs such as rapid blinking of the eyelids, chewing movements, or clonic movements of the hands. And it is associated with a group of genetically determined epilepsy that is onset is usually in childhood or early adolescence, and it is the main seizure type in 15 to 20% of the children with epilepsy. And in EEG, there is generalized symmetrical and 3 hertz spike and will be such that begins and ends suddenly, which is superimposed on a normal EEG background. You should remember the typical point of absence seizures. Typical point of typical absence seizures, that is, there is sudden or brief lapse of consciousness, and this only lasts for only seconds, and no post-ictal confusion, and the bilateral motor sign is very minimal in compared to typical absence seizure. There is the lapse of consciousness is present, but it is of longer duration. It is less abrupt in onset and cessation, and there is more obvious motor signs in typical absence seizures. And in EEG, it is generalized slow spike wave pattern with frequency of less than 2.5 hertz is seen, whereas in typical absence seizure, it is of 3 hertz. There might be diffuse or multifocal structural abnormalities of the brain, and patient is less responsive to anticonvulsants. Now talking about generalized tonic-clonic seizure or GTCS, it is the main seizure type in 10% of all persons with epilepsy. Most common seizure type resulting from metabolic derangements. It is the most common seizure type which results from the metabolic disturbances or derangements. The seizure usually begins abruptly without warning. That is, there is no presence of aura. During the tonic contraction of the muscle, there is a tonic contraction of muscles throughout the body, such as muscles of expiration and the larynx. And the symptoms includes loud mourning or ictal cry, respiration are impaired, and there might be secretion pool in the oropharynx, and the patient may be cyanosed. And the contraction of the jaw muscles result into the biting of the tongue. There is marked enhancement of sympathetic tone, leading to increase in heart rate, blood pressure, and pupillary size. And after 10 to 20 seconds, the tonic phase of seizure typically evolves into the clonic phase, produced by the superimposition of periods of muscles relaxation on the tonic muscle contraction. And the periods of relaxation progressively increase until the end of ictal phase, which usually lasts no more than 1 minute. And in GTCS, generalized tonic-clonic seizure, there is a presence of post-ictal phase, which is characterized by unresponsiveness, muscular flaccidity, and excessive salivation. Their purway obstruction and the bladder and bowel incontinence. And in EEG, that is electroencephalogram, in the tonic phase, there is progressive increase in generalized low voltage fast activity, followed by generalized high amplitude polyspike discharges. During the clonic phase, high amplitude activity is typically interrupted by slow waves to create a spike and wave pattern. And during the post-ictal phase, diffuse slowing that gradually recovers as the patient awakens. And talking about the atonic seizure, there is sudden loss of postural muscle tone, which lasts for 1 to 2 seconds. Consciousness is briefly impaired. There is no post-ictal confusion. And in EEG, there is a brief generalized spike and wave discharge followed immediately by diffuse slow waves that correlate with the loss of muscle tone. And the atonic seizures are usually seen in association with non-epilepsy syndromes. And myoclonic seizure, there is sudden and brief muscle contraction that may involve one part of the body or the entire body. And the pathological myoclonus includes metabolic disorder, degenerative CNS disease, and anoxic brain injury. This all might lead into the pathologic myoclonus, and it is considered to be true epileptic events because they are caused by cortical dysfunction. And in the EEG, there is bilaterally synchronous spike and wave discharges synchronized with the myoclonus. And talking about the etiology of the seizure, that is causes of seizure according to the age group, that is neonates less than 1 month. The etiology or cause may include perinatal hypoxia and ischemia, intracranial hemorrhage and trauma, CNS infection, metabolic disturbances like hypoglycemia, hypocalcemia, hypomagnesia, or drug withdrawal or developmental disorder. And the infants and children that is more than 1 month and less than 12 years, it might include febrile seizures, genetic disorder, CNS infection, developmental disorder, or trauma. In adolescents, that is 12 to 18 years, might include causes might include trauma, genetic disorder, infection, illicit drug use, or brain trauma, brain tumor. And in the young patient, the causes is similar to the causes that is included in the adolescent age, but the autoimmune disease may flare up during the adolescent period. So in young adults, the culprit might be autoimmune disease as well, such as SLE. And other older adults, that is more than 35 years, the causes include cerebral vascular disease, that is stroke, brain tumor, or alcohol withdrawal, or metabolic disorder, or Alzheimer's disease, and other degenerative CNS disease, or it might also include autoimmune disease as well. Talking about the causes of focal seizure, It might be idiopathic. In idiopathic, it might be benign Rolandic epilepsy of childhood or benign occipital epilepsy of childhood. There might be focal structural lesions, or in genetic, it might include tuberous sclerosis, peripheral nerve disease, neurofibromatosis. Uh, other causes include infantile hemiplegia, dysembryonic causes include cortical dysgenesis, or it might be due to mesial temporal sclerosis, and the cerebral vascular disease can be be the cause as well. And the tumors may be primary or secondary brain tumor or trauma, including accident or neurosurgery, and the infective cause might include cerebral abscess, toxoplasmosis, cysticercosis, tuberculoma, encephalitis, or it might include HIV as well. And the inflammatory cause includes autoimmune encephalopathies, sarcoidosis, or vasculitis. These all are the causes of focal seizures. And talking about the causes of generalized tonic-clonic seizure, the first cause may be due to generalization from the focal seizure, that is focal seizure evolving into the generalized seizures. And the genetic cause include inborn errors of metabolism or storage disease and cerebral birth injury, hydrocephalus, cerebral anoxia, and the drugs such as antibiotics include penicillin, isoniazid, anti-malaria drugs, cyclosporine, amphetamines, and the alcohol. That is especially during the withdrawal, the patient may present with seizures. Other toxins such as organophosphates or heavy metal toxins, or metabolic disease such as hypocalcemia, hyponatremia, hypomagnesia, or renal failure or any liver failure. The patient may also land up with seizures. And the infective cause includes post-infectious encephalopathy or meningitis. And the inflammatory cause includes multiple sclerosis, SLE, and the diffuse degenerative disease such as Alzheimer's disease as well. These all are the causes for the generalized tonic-clonic seizures. And now, before talking about approach to the patient with seizure, first we should determine whether this is the true seizure or not. So we should be able to differentiate seizures for seizure versus the pseudo seizure, that is psychogenic non-epileptic seizures. In seizure, the apparent cause is usually absent, whereas in pseudo seizure, it might be due to emotional disturbance or physical stress, and the onset is usually sudden in seizure, whereas it is often gradual in pseudo seizure, and the screaming is present at the onset of seizure, at onset in seizure, whereas it is present during the course in pseudo seizure. And the convulsion, there is rigidity followed by jerking, and in pseudo seizure there is rigidity or struggling, and the biting of the tongue is present in seizure, whereas the biting of the lips, hands, and other people things in the pseudo seizure. The micturition and defecation is frequently or occasionally present in the seizure, whereas it is not present in the pseudo seizure. And the termination of the seizure is spontaneous. Termination of the abnormal body movement of the seizure is spontaneous in the seizure, where it spontaneous in seizure, and it also might be spontaneous or artificially induced in the pseudo seizure. And the video EEG is positive in the seizure. That means it will show some abnormalities in the EEG, whereas in pseudo seizure there is no any abnormalities in the EEG. And the serum prolactin level is raised or rise in seizure, whereas it is usually normal in the pseudo seizure. And this serum prolactin, it is usually rise in generalized tonic-clonic seizure. It may rise around 3 to 4 times than the normal level. But in other types of seizures, such as absence seizure or focal seizure, the serum prolactin is not that high. So serum prolactin is nowadays we don't use it as a marker for seizure or investigation during investigation in the seizure patient. So now talking about approach to the patient with seizure. So first, when the patient is not acutely ill, the evaluation will initially focus on whether there is a history of earlier seizures or not. And if this is the first seizure, we should establish whether the reported episode was a seizure rather than the paroxysmal event. So we should differentiate the seizures versus its differentials such as syncope, uh, pseudo seizure. And we should determine the cause of seizure by identifying the risk factors and precipitating events. And we should decide whether the anticonvulsant therapy is required in addition to treatment for any underlying illness. And in the patient with prior seizures or known history of epilepsy, the evaluation is directed towards identification of the underlying cause and precipitating factors, and determination of the adequacy of patient's current therapy. Now, taking history in the patient with epilepsy, we should go through this all questionnaires, whether so no one is when did you experience the first seizure in your life. It is very much important. If the first episode is present during the early neonatal period, then it might be due to perinatal insults or metabolic disorders and congenital malformation. Uh, if it is present during the early childhood or teenagers, then it might be due to generalized seizures. And the elderly with the new onset seizure, in elderly, if there is a onset of new seizures, then we should think about the pathological structural pathology such as a stroke or brain tumor. Second question, do you experience some kind of warning or unusual feeling at the onset or immediately preceding the seizure? This is we call as aura. If aura is present, it actually indicates the seizure is focal in origin. And in the temporal lobe epilepsy, the aura in temporal, if the epilepsy is in the temporal lobe, then the patient may complain of deja vu or epigastric sensation. If parietal lobe epilepsy, then paresthesia. And if occipital lobe, if the seizure is focal, if the seizure focus is in occipital lobe, then there is visual distortion or transient blindness. And what happens during the seizure? Is there head or eye deviation to one side? Seizures which originating from the frontal eye fields may cause head and eye deviation to the contralateral side. Is there excessive eye blinking at the onset? In occipital lobe seizures, it can present with excessive blinking at the onset. Uh, if the automatism occurs, are these more pronounced on one side or not? So if the temporal lobe seizures, the automatism may include lip smacking and other oral and elementary automatic behavior. And does the patient bite his tongue or lose control of the bladder function? The biting of the tongue and the urinary incontinence is more often seen in generalized generalized seizure, typically in generalized tonic-clonic seizure. And what happens immediately following seizure? That is we call as post-ictal period. In generalized tonic-clonic seizure, there is post-ictal sleep and disorientation and lack of awareness of the surroundings. Hemiparesis or hemiplegia following seizure, that is towards paralysis, it is seen in the focal seizure. And the absence seizure, there is brief or no post-ictal disorientation. And in some patients, the aphasia might be present with otherwise normal awareness. If the seizure focus include the language areas in the dominant hemisphere. And the diurnal variation is the diurnal variation. Now, tonic-clonic and the myoclonic seizures is in primary generalized epilepsy. It is more common on awakening or in early morning. And the temporal lobe seizures, it can occur at any time. And if the frontal lobe seizures is involved, then presentation might be a nocturnal presentation. And we should also ask about the triggering factors or precipitating factors such as sleep deprivation, misdose of anti-epileptic drugs, if the patient is treated with anti-epileptic drugs, and the recreation drug misuse, physical and mental exhaustion, intercurrent infection and metabolic disturbances, and flickering of lights, including TV and computer screens, alcohol consumption, use of antihistaminics, and the uncommon cause might include loud noise, music. We should also ask about the frequency of the seizure. It is important to determine the response of the response to the treatment and what has been the maximal seizure period since the seizure onset. It is to determine if any specific anti-epileptic drugs was more efficacious than the others. एकछिन है एकछिन मलाई 1 मिनट दियो है।
सर
हेलो सुनेछ?
यस सर सुनिरहेको
ओके, यहाँ घरमा अलिकति काम चलिरहेछ कि त्यही भएर आवाज अलि डिस्टर्ब भएर होला है। So we should also ask if there is more than one kind of seizure. So the patient might, same patient might have focal seizure as well as a generalized type of seizure. So it is very much important for us to determine the types of seizure in the patients. And as the patient sustain injury related to seizures, the this is usually the patient will sustain injury related to seizure usually if the patient don't have aura. If the aura is not present, the patient may generally have injury during the seizure. That is aura is usually present while in the focal seizure, or it is absent in the generalized type of seizure. And what is the frequency of visits to the emergency department? It is also most important to determine the degree of seizure control. That is the efficacy of the treatment. And we should also ask about the past medical history. In the past medical history, we should go through central nervous system. If there is any CNS infection such as meningitis, encephalitis, Lyme disease, cystic fibrosis, or tuberculosis, and the head injury is especially associated with the depressed skull fracture, intracellular hemorrhage, loss of consciousness, or prolonged amnesia. If there is brain tumor, past history of brain tumor, or past history of CVA. In the family history, specific epilepsy syndromes and genetically mediated neurological disorders that have seizures as one manifestation. That is then the specific epilepsy syndromes include familial neonatal convulsion, benign Rolandic epilepsy, juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, or mesial temporal lobe epilepsy. And the drugs and the other substances that can cause seizures. I have already told about this before. It might include penicillin or anti-malarial drugs, cyclosporine. And in examination, if the asymmetry is present in the size of the limbs or one half of the body, that is hemiatrophy. It is usually seen in perinatal cerebral insult. If there is marks or ulceration on the side of the tongue or oral mucosa membrane, that is biting of the tongue. It is usually seen in GTCS. If the gingival hyperplasia is seen, then it might be due to the excessive dose of phenytoin. Or if there is a different transcontracture, then it might be due to the chronic use of barbiturates. Multiple bruises or injuries, it is related to the false secondary to the seizures. And if the engaged nystagmus, diplopia, and difficult in tandem walking present, it might be due to the toxicity related to carbamazepine, phenytoin, and lamotrigine. In general physical examination, we should include or we should search for signs of infection or systemic illness. Organomegaly may indicate metabolic storage disease. We should auscultation of the heart and carotid may identify CVA disease, and the signs of neurocutaneous disease such as neurocutaneous disorders such as tuberous sclerosis or neurofibromatosis. We can see the cutaneous lesion during the physical examination. An investigating the first seizure. A seizure is the symptoms of the underlying pathology rather than the disease, and the investigation are directed at identifying the precipitating etiology and condition that can be arrested, reversed, or treated. And the detailed history and physical examination can provide direction to the extent of investigation. I have already told you about the history, how to take a history in the seizure patient. So we should include all these things. There's other precipitating factor or physical examination, or detailed history and physical examination should be done. And talking about the investigation in the case of epilepsy, EEG is the EEG is the diagnostic investigation, diagnostic of choice in the epilepsy. So the EEG can be standard EEG, sleep EEG, or EEG from